Hi, Dr. Sue. My name is Akash Prashad, and I am in a group with three others. Let me start the screen share. I'm in a group with three others, and we are presenting on the national drug crisis. My group members are, as you can see, Lanessa, Brant, Reid, Forte, and Melissa Jusino. I'm presenting because they said I was the best public speaker. I'm pretty personable, so that's why I'm speaking on behalf of our group. We found it was quite difficult for four people to talk and try to get the program correctly in a cohesive manner. So we talked about it for a little bit, and I wanted to present the rest of it to you today. Here is our certificate of original authorship, and so you can see that we all signed it. It's dated for today, and we'll be submitting it to you for this class. So first slide. Here we're talking about the summary of national drug crisis and who it impacts. Today, there's been over 70,000 deaths by drug overdose alone in 2017. On average, we've been averaging around this number of 70,000 drug overdose, every year. Since then, of those, opioid overdoses are approximately 47,000, 50,000 deaths a year. And these are due to Schedule II medications. Schedule II medications being drugs like fentanyl, oxycontin, hydromorphone. And we're really starting to see a lot of these drugs really affecting our healthcare system, as several of us are emergency medicine and trauma nurses. And we see this where we're on the front lines of this issue. We're there all the time, and we see these patients coming in to the emergency department and into trauma, and they're having issues, and they get intubated if they're overdosed, and a lot of them don't make it, depending on how sedated they are. They'll come in with a Glasgow coma scale of 15. Then there'll be 8, then all of a sudden there'll be 3, and they'll be having to been intubated because they're not protecting their airway, and it's a whole issue. And so people are dying from these drugs every year, and we really want to shed some light on the national drug crisis, and it impacting all these lives, their families' lives. It's us in the emergency department, we're getting hit with all these patients needing the resuscitation that we can provide, the intubation that we can provide. Hopefully, some of these people want to get better, and maybe we can provide them with our social work a way to rehab themselves. But this crisis has really been hitting the United States, and it's causing some issues. As you can see here, the background behind this national drug crisis is originally the New England Journal of Medicine, New England Journal of Medicine released because of the Controlled Substance Act in the 1970s. New England Journal of Medicine said there wasn't as many issues with these narcotic drugs. And what happened is there was an increase in the amount of prescribed drugs. Now, 80% of heroin users have been found to have started misusing opioid drugs before they started taking heroin. So then you have all these IV drug users. You're spreading issues. You're spreading diseases like hepatitis A, hepatitis B, hepatitis C, HIV, AIDS. You're getting all into these viral infections that can be spread. And this is just a secondary indication behind a national drug crisis, which is our primary topic. I'm just showing you how many issues there can be and why this should be taken so seriously and be identified as a national United States epidemic, and why there needs to be action against this from happening. So what happened basically after the Controlled Substance Act in the 70s was 50 years later, we're seeing the issues because of it, but there was increased prescribed amount of narcotics. Then these people who took these narcotics started using illegal opioids. Like I was saying, they're using the heroin. And now everything's falling apart. People are using these all over the place, and they're coming to the emergency departments. They're coming into trauma, and there's just issues arising everywhere. So here's the rise of the Prescription Drug Monitoring Program, the PDMP. What that is it's a program that's an electronic health record system that's initiated in each state. So meaning I'm in Florida. So Florida has a program called eForce. We use that in an emergency department in trauma, that we can put in a patient's name, their driver's license, any kind of identification, and pull up if they were prescribed a narcotics prescription, either recently, where it was prescribed, what was prescribed, dosages, amount, and we can really see where they're coming from. This really prevents people from shopping for doctors. Like, I know this was a huge issue back in about 10 years ago down in West Palm, and people were shopping for pills, getting a bunch of opioid-based medications, and then driving them out of the state. And then because these PDMPs are only governed by each state, you get into an issue because Georgia doesn't access our software, and there's no federal mandate for that to happen either. So the proposed policy changes are, which I think is phenomenal, and this is why we're very happy to talk about this topic. The prescription drug monitoring program, these PDMPs, they are an electronic EHR that we want to be able to be used nationwide, meaning we want Georgia to talk to Florida and Alabama, and so that when patients go from one place to another place, we'll know that they've been getting prescription narcotic medications. And then since they've been identified, well, hey, we know you already have some. They're selling them and making the epidemic even worse for other people, or they're using them themselves and causing detriment to their own body, which, nurses and physicians, we don't cause people harm. And so that's against the code of medicine, I feel, in general. And since the last decade, there's been 3 times the amount of overdoses in the United States. And so that just shows that there's just a huge predominant issue that we're experiencing right now, and it needs to be stemmed. So alternatives that we've identified, there's mainly 3 alternatives. The primary alternative is that patients should already be spoken to. Like, I know here in Florida, there's a DARE program when you're in 5th grade, when you're in elementary school, about children, learning about narcotics and drugs and why you shouldn't be taking them. But we can see we're already at a point where many of the states have these programs, and they're still having kids grow up to take these narcotics. And so we're at the point now where we're pushing for these PDMPs, these prescription drug monitoring programs, to be used, in all states, but communicating between all states, so everyone's keeping tabs on everyone. We want them to be, one, mandated in all the states. Like I said, only 22 or 49 are being used. We want them to be mandated in all the states. But on top of that, we want them to communicate to the other states, so that there's no way for people to get more medications that are more than medically necessary. And I believe a step further, another alternative is if you identify somebody, like let's say law enforcement intervenes, which we'll talk about later, there should be a way for people who want to get better, who want to get clean, who want to be rehabilitated. There should be ways for them to safely do that without worries of going to jail or getting something put on their record. If somebody wants to get clean, I believe that we should help them, because it will help us in the long run. It'll decrease healthcare strain. It will increase, it'll increase the ability of the person to be a benefiting member of society. It will decrease costs on the government. There's only upsides to helping others. And that's one of the beauties behind medicine and nursing. Now, the cost of these prescription monitoring programs are between $500,000. So the advantages of using these PDMP programs are the universal use of it, that anyone can use it that's a healthcare provider. So pharmacists, physicians, nurse practitioners, since we are future nurse practitioners, the real-time accessibility of the program, meaning that if somebody goes down the street and gets a narcotic prescription, I'll know in real time, 20 minutes later, that, they came to see me at my urgent care, that I know that they already have a script that was written someplace else. So I'm going to be like, listen, I know you're just shopping around, or, it'll shed light on what they're actually there for, and really start showing people that either they'll separate people from actually having issues and needing help, and people who are trying to beat the system and trying to hurt themselves and hurt others while doing so. Now, or who need help and just don't have the ability to get help and are trying to sedate themselves. Now, this can be actively managed, which is wonderful because it's a public health tool. I know public health nursing is a big thing, and using this program, you can really identify this patient population, where they come from, their needs, and we can address their needs, and we can really move forward. The ease to use and access is a big thing. As long as everyone can use it and has access to it, it'll just make a program better and better for everyone. Now, here's some downsides. The cost of the program, it's on average $1 million per state to bring this program into fruition. And what that means is and with the cost of it being almost $150 to $1 million operational cost per year, you're looking at $75 million a year for this program to be operated. And so that's a heavy burden on the government. But when you think about it, medication adherence costs $300 billion to the government. This narcotics issue cost the government $78.5 billion. And so when you look at $75 million on average, it's not a big deal. Like, it honestly is small in retrospect. And like it says in the bottom of future costs, like, is there a real true cost to human life? As of right now, I know in emergency departments, patients, when they need help, you come to the emergency department, we will take care of you. It is by law here, and especially here, I know in Florida for a fact, if you need help, you come here, we will take care of you. And so there's no cost on human life. So to me, why stop with doing that, which costs millions and millions, if not billions of dollars more, than to initiate this system where PDMPs speak to each other and promote well-being to our patient populations. Now, I believe future costs can be mitigated with the unification of the federal government, the state government, law enforcement, and hospital organizations, meaning that people who either like pharmaceutical companies who make these drugs, the federal government, the state government, on every level, the PDMP, which is originally state government level, the federal government intervenes. And then people talk to everyone in the United States. Everyone has an idea where the issues are, the needs are. People can identify them and take care of them. Yes, there's some issues that people be worried about the government looking at their information, their data, but we're only looking to help. Law enforcement can be brought into this, and they can have a joint venture where if somebody they identify as being addicted to these drugs, being a burden to themselves, hurting themselves, they can bring them to the hospital organization being a part of this, and we can help people find a way to get past their addiction and move forward so we can lower the amount of people who are dying to an unnecessary cause. This is not some people argue it's a disease process, but it's not a disease process. It's people inflicting this on themselves. So the process for evaluating this change, like I said before, it's going to take a unified front between the federal government, the state government, and law enforcement officials. Everyone needs to be bound together to do so. In doing so, there will be a decreased strain on the healthcare system because there will be less amount of hospital admissions and readmissions due to the overdoses. There will be a decrease in the amount of national health care costs because there will be less people going to the hospital to be getting taken care of. There'll be an increased number of sober patients, like I was talking about earlier, reintroduced into society. Narcotic medication will only be used as indicated. So patients will be medication adherent, which is another issue that we have in the United States. Patients will be motivated participants in society, as well as everyone will have either saved money and promoted life or made money and promoted life. It's a win-win for everyone. Now, currently the policy supporters, there was an article released just recently by JAMA, which is a very well-known magazine, that said nearly 50% of Americans have been or know somebody intimately who has been addicted to drugs. And what that goes to show you is that the current supporters for this change and why policymakers need to know about it, and this is the biggest thing about this policy class, is let's just say 1 in 2 Americans know somebody like this. There should be no problem implementing a policy change. Every physician, every nurse, every law enforcement officer, the people who see this every day, the parents, the siblings, growing up in rural communities, we see people who have this affect their lives. Those are the current supporters of change. The over 130 Americans who die every day, their families are supporters. The future supporters and the ones who can really promote change is, like I've been talking about, this unified front between pharmaceutical companies, the hospital organizations, American citizens and law enforcement, federal government, state governments. If everyone can communicate, and we learn this in nursing, communication, delegation, closed loop communication, the big three that they learn in nursing school. Communication has never led to a decrease in health promotion. And I believe if we all can communicate and keep an open mind, an open line of communication, we will reach the end of this tunnel, and we will identify a way to solve this national drug crisis, or at least stem it. If you can bring it down and at least help a few people, at least you're saving a couple more lives than you did yesterday. So in summation, as we've been saying and reiterating, most of us work in emergency in trauma medicine. We see what this drug crisis brings through our doors all night, and the ability to reduce the amount of accessibility to these drugs, people not wanting to overdose, people not wanting to hurt themselves, and really bringing this to the eyes of policymakers and saying, hey, and if only 1 in 2, I guarantee you some of them have either had addiction problems themselves or know somebody who has. With numbers like that, everyone is on board and everyone is a supporter. But the primary characteristic, like the sentence says, of healthcare and of nursing in particular, is just 4 main facets. We always promote patient safety, patient satisfaction, patient longevity of life, and fourth, the increase in quality of their life. And I feel like this national drug crisis, in doing so, we will not only do all 4, but a 5th one will be added, and we will promote preservation of life. And if that's not the number one goal of medicine, then I don't know what is. Thank you for listening. My name is Akash Prashad. This was my group with Lanessa, Brant, Reid, Forte, and Melissa Jusino, and we were talking about the national drug crisis. I hope you enjoyed it, Dr. Sue. Here are the references we used, and thank you very much.